Great. Thank you, obviously, for the contribution of Dr. Claudia Redden and Dr. Margot Montjoy. Unfortunately, not live during our session, but our next speaker will be live in our session. Our next speaker is Professor Alan Currie. Professor Currie is sports psychiatrist in Newcastle in the UK, so involved in all the IOC activities when it comes to mental health in elite sport. Alan, good morning. Nice to have you live in the session. And obviously, the floor is yours for the next 25 minutes.
Thank you, Vincent. I'm having a little trouble getting this going. Hang on. I do apologize. Give me one more go. It's the trouble with being live, isn't it? There we go. Specific cases in elite sport. As Vincent said, and I'm very grateful to him and to our connection for the opportunity to present today. So thank you for that. But as Vincent said, I'm a psychiatrist. I have a full-time job in a mood disorders research and treatment facility in the northeast of England, and a part-time job with the English Institute of Sport, where I'm a psychiatrist on their mental health panel. I've got two cases to discuss today that are entirely fictional, so there's no confidentiality issues here, but they do illustrate a number of points about mental health conditions and how they present in athletes and how we try and support athletes to get well and to get back and playing and competing again. The first case, as I said, it's fictional, is of Sarah, who's a 26-year-old rower. She competes in single sculls events. So she's on her own in the boat with an oar on each side. For those of you who don't know about rowing, she's highly ranked, top 5 in the world. This is pre-Olympic year we're talking about, fictional case, with a clear target to get onto the podium and possibly even a sniff at a gold medal in her event. She presents just after the Olympic qualifying race, where she finishes second. And because her country only gets one boat, she's not selected, so her Olympic opportunity has gone. A few hours later, she's with a physiotherapist who she knows well, and she confides. She's distraught, she's disappointed, and she voices some suicidal thoughts, which are always a concern. And the physiotherapist arranges the same day for her to see the team doctor who's on site. The team doctor has a consultation, and Sarah talks about how low she feels. There's a concern that actually she's been hiding depressive symptoms now for some time. A PHQ-9 is a screening instrument for depressive symptoms, and it gives you a score that rates depressive symptoms as either absent, mild, moderate, or severe. It's actually included in the SMART, which Vincent will be telling you about shortly. Her PHQ-9 score, done by the doctor, takes her into the moderately severe level of depressive symptoms. And because of that, and because of the concerns about suicidal thinking, she's referred to a sports psychiatrist who's nearby and who's known to the team.
Sorry, Alan, to interrupt, just 1 second. Can you move your slide forward, because we are still seeing only your introductory slide.
Right. I don't know what's happened.
Yeah, so now it's a second slide.
Yeah, so when I do that, it doesn't move.
Yeah, but okay, strange. Perhaps you just have to click with your...
If I do it like that, does it move?
Yes.
Okay, well, if I just try and get the screen as big, I don't know what's happened. Okay. If I present it like this, you happy with that?
Yes, I think we can see your slide.
Okay.
Thank you.
Okay, so Sarah is the sculler who tries to get to the Olympics, who misses out on her qualification place, seen by the physiotherapist, describes suicidal thoughts, seen by the doctor who's concerned about how depressed she is, and is then referred to, let me just, there we go, is referred to a psychiatrist who's known to the team. The history that presents there with the psychiatrist is how tired she is. She has no energy. She lacks motivation. she feels low. Those are the core features of a depressive disorder. So we're moving here from symptoms into disorder, and that's quite an important distinction. She's tired, she lacks motivation, she feels low, she can't enjoy things, what psychiatrists and psychologists call anhedonia. Alongside that, her concentration's poor, she's not sleeping very well, and her appetite is diminished. So there are clear symptoms there suggestive of a depressive disorder. And the psychiatric examination confirms that. She appears low, she's quite unreactive and unhappy throughout an extensive consultation. Her thoughts are preoccupied, and this is common. Her thoughts are preoccupied not only by failure, but what failure means, what coming second actually means. And strong in her thoughts were the thoughts that she had let others down, that those who had invested time and energy and finances to support her, especially her family, had been let down by her performance. She did have some suicidal thoughts. They were quite non-specific. She thought the future was empty and hopeless. She'd be better off if she wasn't here. She found these thoughts very distressing, and they would come several times a day, but only momentarily. They weren't associated with any strong intent or any plans to act on them, and she often thought of her family, which was protective. The psychiatric history also picked up some background details about her past medical history. Nothing terribly significant. She had an injury, as many athletes do, but had made a full recovery, and no previous mental health concerns. There was a family history that she presented, unclear of the details, but she knew that her father had been a heavy drinker and might have been depressed at some point in the past. So something in her heritage, something in her family history there. We get interested as well in sort of pre-morbid functioning, about how people are before they develop symptoms, before they become unwell. Like many athletes, she was a driven perfectionist. Now, there's nothing wrong with being a perfectionist. It's associated with success. It's overrepresented in academic spheres as well as sporting spheres and in other areas of life. But the issue about perfectionism is when it becomes dysfunctional, and it's when you marry those two attributes, when those two attributes come together, setting high standards alongside being very self-critical. And that gives you the fertile ground for depressive symptoms to emerge and to develop. High standards and self-criticism. So you set a high standard and you just fall below that standard, and you berate yourself repeatedly and see yourself in a very negative light as a consequence. She'd also recently been overtraining, which came out in the psychiatric background. And by overtraining is very difficult to judge in a high-performance sports environment, but there are some pointers that we look to. Things like training when you probably should be resting. We know that rest is necessary for the physiological adaptation of sporting excellence, and training when you should be resting, training in secret, doing extra training that's not part of the program that your coach doesn't know about. And she was doing a lot of this, a lot of extra sessions in the gym and a lot of extra endurance sessions. She would go for a run after her late morning session on the water. And there's something that's been touched on already this morning, and I've tried to capture it here. It's about the need to win. And in the early stages of a sporting career, say in adolescence, when you're enjoying your sport, when you're getting to grips with it, when you're winning regional titles and getting nationally known, success is enjoyable, it's pleasurable, it's fun, you can celebrate it. Sometimes for some athletes there comes a point when you don't enjoy that. It's more about relief that you have won. That need to win, to sustain your mood, to sustain your identity, and stopping enjoying success. And she reported that. The psychiatric formulation that the psychiatrist pulled together began with this. Firstly, picking up that we're moving here from symptoms into the realm of disorder. There is a condition emerging here, a clinical condition, that the psychiatrist would have labelled a major depressive disorder. First episode, and in terms of its severity, it was moderate. And moderate's important when we come to think about treatment options in a moment. Another important thing to do, and I'm sure Vincent will cover this when we look at the SMAT, is we don't just diagnose a single condition. Many conditions are comorbid, they co-occur, and it's common, for example, to see depressive symptoms alongside maybe some substance misuse, or to see an athlete with chronic pain as a result of an injury developing some depressive symptoms. So sometimes conditions are comorbid, but there were no significant comorbidities in her case, so it seemed fairly straightforward. Psychiatrists tend to think about a formulation in terms of what might predispose an athlete to a problem, what might trigger it, what might be the precipitant, and what might be a perpetuating or a maintaining factor. And the predispositions that appeared in her case with the family history, her heritage. She had an absent father, and she elaborated on this in the consultation, an absent father who was hard to please, and a lot of her sporting performance through adolescence was in an effort to win his affection and respect. Perfectionism, and we go beyond that. Perfectionism there's nothing wrong with being a perfectionist. It's associated with success, but when you combine those two attributes of high standards and self-criticism, that's when it becomes problematic. Those were in her predisposition. Precipitants. Well, the immediate and obvious trigger was that she didn't qualify, but it wasn't just that she didn't qualify, it was how she appraised that, what that meant, the personal meaning. I'm a failure, and more especially, I have let people down. And the overtraining was a clear precipitant as well. And there's an interesting intersection between overtraining, becoming physiologically depleted, what that does to your stress hormones, to your immune system, and how that might relate to depressive symptoms. And then the final thing was the perpetuating factors. This was someone who had an empty life ahead of her because she had no plan B. There was a plan A, which was to qualify for the Olympics, to get to the Olympics, to make the final, to get onto the podium and possibly to the top of the podium, with no plan B, nothing. It was also noted that she was quite a solitary individual. She's in an individual boat in a sport that's quite individual. So she's solitary and she doesn't readily confide in others. She had a relatively underdeveloped and small social support network. Some treatment options were reviewed. The first one was rest. She's been overtraining, she's depleted, she needs a bit of a break. So there's some light exercise, but it's not described as training. So she's allowed to do a little bit and she agrees to that. Psychological treatments are reviewed. And a couple of important points here. One is it's helpful to have a range of psychological therapies available so that you can match them not only to the individual, but also to be able to deliver them in the environment of elite sport. Many of you will have heard and know about CBT, which is a strongly evidence-based treatment for depression, which is thought to be very particularly helpful for athletes. Athletes like things like agendas and targets and so on. The CBT matches that. Interpersonal psychotherapy is a particularly effective treatment for depression, and there's been a lot of recent interest in a treatment called acceptance and commitment therapy. And part of the consultation would be to discuss the elements of all of those different therapies so that we get a good match between the therapy and the athlete. Medication considerations have already been reviewed extensively by Claudia in terms of issues around, for athletes especially, tolerability, safety, and performance concerns. Specifically in relation to medication, when symptoms are at moderate severity, then antidepressant medication is an option. We would more strongly advise it if symptoms were more severe. And Claudia mentioned that point that all sports psychiatrists are aware of, and it's the need not to compromise psychopharmacology if someone really needs and would benefit from that treatment. But here we're in a situation where it's at the level of an option rather than something that is strongly advised. There's a limited evidence base for prescribing antidepressants in sport. The best evidence that we have comes from expert opinions that take an approach of individual prescribing. So knowing enough about a range of different medications so that you can match them not just to the illness, but to the athlete and the physiological and biomechanical demands on the athlete. And there's a couple of references I've given you there where some recommendations are made about treatment, considering drugs like the SSRI class, like sertraline or fluoxetine, for example. Another issue here, and one of the reasons why the team chose this particular psychiatrist, was because of their ability to join the multidisciplinary team around the needs of the athlete to support not just a treatment plan, but a recovery plan. Don't worry too much about the details on that slide. Focus on the principles of multidisciplinary working. And the three important principles are that it's athlete-centered, the athlete's in the middle of it, and all the decisions are made for the athlete, about the athlete, with the athlete involved. That there's good communication between all the professionals, between the coaching and scientific team that are part of the performance team, and the clinical, the medical team, the team doctor, the therapist, the psychiatrist. And a helpful concept here is that of a sort of inner circle of people around the athlete, those within the team, maybe a sports psychologist, maybe a nutritionist, maybe a strength and conditioning coach, maybe a technical performance coach, and an outer circle of available experts. And for an injury, that would be the best orthopedic surgeon that you know within a 50-mile radius. And in this case, it would be the best psychiatrist or clinical psychologist that you know within a 20, 30, 50-mile radius. I mentioned overtraining and depression. That's an interesting area because there's clearly symptom overlap. Claudia presented you a slide looking at the symptom overlap between concussion symptoms and depression and anxiety. There's a symptom overlap here too. Some have reported diagnostic issues, that if you see a sports medicine doctor, they will pick up on the overtraining quite readily and might diagnose an overtraining syndrome, but might miss the depressive symptoms. If you see a mainstream clinician who doesn't work in sport, they might pick up the depressive symptoms but miss the element of overtraining. So there are some diagnostic issues there. There's also an interesting issue that needs further investigation, which is how people respond to rest. The overtrained athlete will respond well to a period of rest, but the depressed athlete might not. The depressed athlete might not respond very well to being taken out of the sports environment, to having a period away from the social supports and the training that gives them structure to their daily life. And there's some interesting work going on at the moment looking at depression and immune function, and I've summarized some of it there. Immune function is temporarily suppressed by high-intensity exercise. And if you're intensely exercising for a sustained period, as many athletes do during periodized training, then you enter into a period of more enduring dysfunction. And at some point that becomes overreaching, and at some point that becomes overtraining, and immune dysfunction is associated with that. But we also see altered immune function in subtypes of depressive illness. So some people who have inflammatory markers and altered immune function are overrepresented in depressive cohorts and tend to have a poorer prognosis for the depressive illness. So those are some of the issues around Sarah. I apologize for the little glitch at the beginning and that you can't see the full slides as I intended. I have a second presentation, a little bit shorter, this one. This is a footballer. And again, it's entirely fictional. You can tell it's fictional because I always write a fictional case about footballers and introduce an ACL injury. I don't know why I always do that. Footballers got other injuries too. But Steve is a 24-year-old central defender who had a severe ACL injury a year ago and had to have reconstructive surgery. His rehabilitation, as it often is after ACL injuries, was difficult. It was prolonged. He had a couple of false starts with it. And he was out for 8 months in total. During that 8 months, he was bored, he was lacking motivation, and he began to become anxious and uncertain about his future, especially when the central defender who replaced him was starting to shine within the team. So he's getting quite worried about his place in the team, but he's now back in full training. Some of his teammates notice a change, and they notice some quite non-specific things. They notice that he's a bit more irritable and short-tempered, that he moves away from being someone who's always well-groomed and takes a great deal of care about his appearance, about his clothing, about polishing his shoes, about always being very smartly dressed. He's now less attentive to that. And he's occasionally quite uncharacteristically late for training. He was a dedicated player who was often first into the training facility in the morning, and now he's occasionally late. And they socialize together, and he drinks more than he used to, and more than the others when they're socializing, say after a training session in the afternoon. And someone close to him nudges him and prompts him to see the team doctor to have a discussion about this. The team doctor, in confidence, establishes a history like this. And it's a history of alcohol use and about 3 months of binge drinking. So discrete periods of heavy drinking. Sometimes with his teammates after training, but as we've mentioned, he drinks more than they do, and certainly more than he used to. He does this 3 or 4 times a week. He'll have 4 or 5 pints, because he's English, it's pints we drink, 4 or 5 pints of beer, and then he'll move on to some spirits, which again is very uncharacteristic for him. He'll have 2 or 3 large measures of whiskey after he's had his pints. He's getting some tolerance to this. It's beginning to have less and less of an effect, and he's beginning to get used to it, but dependence symptoms aren't reported. He's referred to a sports psychiatrist who, again, is known to the team and who lives and works locally. And the same history is, but in a little bit more detail, is established. And the gradual increase in alcohol consumption over a year, and especially the last 3 months. Similar history in terms of quantity and frequency, the tolerance that's developed. His alcohol background was really quite limited. He'd had his first drink in his mid-teens, but was far from being a regular drinker. In fact, he'd looked after himself very well because of his involvement in sport. There was a family history again. His father was a problem drinker who was a bad-tempered individual. Steve also reported that he was a shy person, that he didn't always shine in social situations, but the disinhibiting effects of alcohol allowed him to do that, and he quite liked that. There was also a history which others in the team weren't aware of, that he'd actually been in an altercation, a fight, when he'd been out one evening with some teammates and when he'd been intoxicated. And again, that search for comorbidities. There are other conditions that often go alongside an increase in alcohol use, conditions like depression, anxiety, PTSD, chronic pain, and others. And the history didn't pick up any of those comorbidities. The psychiatric examination, the mental state examination, is the highlights are listed there. He was unshaven, uncharacteristic for him. He did smell strongly of cologne, which you often see in people who are drinking. It masks the smell. His mood was reactive. He was quite engaged in the consultation, didn't appear depressed or anxious. His speech was coherent, it wasn't slurred. He linked his drinking problem to his boredom and frustration, and his anxieties about his place in the team. He was aware of the harm that alcohol can cause, and he did want to make some changes to his behaviour, but he was afraid of admitting to the problem, to the coach, for example, finding out, and afraid of his place in the team if he acknowledged it. Many of you, especially those who have a background in psychology, will be familiar with a diagram a bit like that, which illustrates a model of change. This has general application to any behavioural change, but specifically in relation to Steve, it's about changing his harmful behaviour of his alcohol consumption. Before we make a change, we're maybe in a state of pre-contemplation. We've not yet begun to think about it. Then we move helpfully to a state of contemplation. We might be starting to think about doing something about a behaviour. Then we begin to prepare for that, to take some action. And having taken the action and changed the behaviour, the difficult task then is maintaining that change. And if we're able to maintain it, then we move out of that cycle and into something happier and healthier. And if we can't maintain it, we relapse, and then we're back at the beginning of the cycle in a pre-contemplative stage. And I've changed colour there at preparation, because that's probably where I would have put Steve, at the kind of preparation stage. Maybe there's an argument for saying that he's somewhere between preparation and action, but he's aware of the issue and he wants to do something about it. So he's moved on from contemplation to preparedness to take some action. And that's helpful because that helps to engage him in therapy. An important element, as with Sarah, is that some kind of risk assessment is undertaken. What are the risks here? And we break that down usually into 3 broad groups. We think about the risk to the individual, we think about the risk to others, and we think about protective factors. Those are important. Protective factors are especially important because if a protective factor disappears, then risk can increase quickly and substantially. The risk to himself, suicide wasn't an issue. There was a risk of accidents if he was drunk, and other risks that go around that, things like sexual indiscretions if you're intoxicated, or that you might drive when you're drunk. So the risks to self are important to think about quite broadly. There's a risk to others. He'd been involved in an assault. Someone else had got hurt. He's 24. He's a footballer. He's fit. He's strong. He's powerful. You could break someone's jaw if you got in a fight. If you're Steve and you're fit and strong. The protective factors were there. He had an understanding of what the problem was, and he was ready to make changes. A rating scale was used. This is a rating scale that very simply asks about alcohol consumption, recent alcohol consumption. Again, it's included in the SMAT. Each item is scored on a range of 0 to 4, so you get a total score of 12. And at 4 or more, it has good metrics, a good sensitivity and specificity for picking up potential problems. Steve scores 9, so he's well into the area where we would become concerned. And like Sarah, the psychiatrist conducts constructs a formulation with a single diagnosis of alcohol use disorder that is moderate, with no significant comorbidities. So we're moving on from again, we're able to pick up a disorder here because we have the detailed history and assessment. So it's not symptoms, it's disorder. And again, the formulation includes thinking about the predisposition, the precipitants, and the perpetuating factors. And the predisposition that was picked up here, his shyness was thought to be a bit of a predisposition, especially what happens when he has a drink and what happens to his shyness when he's had a drink. And the family history might be important too. The precipitants, he mentions the boredom, the frustration, the uncertainty, and there's an easy availability here. There is a culture within the team at least once or twice a week of going out and having an afternoon session of playing bar games and drinking after a training session, and a culture of doing that after an important match too. And the perpetuating factors, and these are often the most important when we're thinking about alcohol use disorder. Alcohol, as most of you will know, is a pleasurable thing to drink in moderate quantities, and we can quite quickly habituate to the effects of that. And it's often the perpetuating factors that are the most important and the most difficult to address. It might not take much to introduce you to alcohol, and once introduced to alcohol, you can get stuck with it. And the perpetuating factors for Steve were the disinhibiting effects, the positive impact on his social functioning, at least initially, and the development of tolerance, and therefore the need for increasing quantities. The management plan that was put together involved some sessions with a counsellor, using some motivational interviewing technique and aiming for abstinence. He was also given some information on local support groups. Pharmacological treatments, again, as with Sarah, they get considered but weren't thought to be necessary in this case. They're usually reserved for more severe problems, as we illustrated in the earlier case. So pharmacological treatments would probably only be used if there were more severe problems. For example, to manage withdrawal symptoms. And other pharmacological approaches are sometimes used. Naltrexone can be helpful because it reduces the reward effects that you get from alcohol, so it becomes a less rewarding thing to drink. So all the positive reinforcement and maintenance that comes from alcohol is removed. Excuse me. Acamprosate is a medication that's used to sustain abstinence once it's achieved. And occasionally, but it's quite an old-fashioned treatment, disulfiram is used. Disulfiram will create an unpleasant physiological reaction if you drink alcohol. So drinking alcohol, instead of becoming a pleasurable thing, becomes quite an aversive experience. And that's still occasionally used, although it's quite an old-fashioned treatment. They were all considered and discussed with Steve, but weren't necessary in his case. And that's how Steve's problem was managed and addressed. I've included some references here. These will get shared later, and some suggested readings, including if you're interested in the case studies approach to sports psychiatry problems. Many people find it a practical way of thinking about problems and how they might be addressed. It's sometimes a bit easier to read because it's more real life than reading something a bit drier, like an academic review. If you're interested in the case studies approach, then I can recommend that book to you. Many thanks for your attention, and once again, a final apology for the little glitch earlier, so sorry about that.
Thank you, Alan, for your contribution. Not sure whether we have any question for Alan. Evert, perhaps, do you have? Oh, yes, there is a question from a colleague from Amsterdam, Leendert Blankenvoort. A psychologically safe environment requires actors in that environment with a good mental health. What about the mental disorders of coaches, trainer, team, owners, and so more? Well, Alan?
Would you like me to take that one?
Yes, please.
That is important, and it gets neglected. Claudia, in the review that she led and I was part of, listed about 15 things that were important to research. And we do need to look after the mental health of the athlete's entourage as well. It's often said that a sports coach, for example, if you list all the stressors that the athlete has, the sports coach has almost all of the same stressors. How they're judged by performance, all the traveling that they have to do, all the time they have to spend away from home and their social supports. And they probably have some of them to an even greater extent. Coaches will often talk about having the the responsibility without the power. You're judged by results that actually you have less influence on than if you're on the pitch. If you're watching from the sidelines, you can't actually do a great deal about what's happening on the pitch, but you still have a lot of responsibility for what's happening there, just to give one example. So yes, coaches have many of the same stressors and sometimes even more of them.
Thank you. Thank you, Alan, for your contribution.
Thank you.